to More Good Days, the official podcast of Haven Headache and Migraine Center. I'm your host, Neda Hindiyeh, founder and chief medical officer of Haven. Our podcast aims to help you stay informed about the latest research, policy updates, and most importantly, practical advice for managing life with headache and migraine disorders. This podcast is designed to provide you with the valuable insights and support on your journey to more good days. We're in the middle of this 4-part series focused on the topic of women and migraine. In the last episode, we covered migraine and pregnancy, and in this episode, we'll discuss migraine in postpartum and breastfeeding. Over the next 2 episodes, we'll explore postpartum migraine, breastfeeding, as well as migraine during menopause and perimenopause. So for this series, Isaac and I are joined by Dr. Susan Hutchinson. Dr. Hutchinson is a personal mentor and an amazing clinician. Without her, Haven would not be possible. She's a clinical director focusing on women's health and brings a unique perspective to headache medicine from her background in primary care. Before helping to found Haven, she established the Orange County Headache and Migraine Center and is the author of A Woman's Guide to Managing Migraine. And just a quick note before we dive in, we strive to ensure that all statements made in the podcast are clinically accurate, but it's not intended to serve as medical advice. Please consult with your provider, or if you're in California, make an appointment with one of our headache specialists at havenheadache.com.
Before we get started on this episode, I want to acknowledge that we are using the term woman to refer to folks that experience menstrual cycles and pregnancy, perimenopause, and menopause in this series. However, we do acknowledge that there are many folks who do not identify as women who may experience these cycles of life.
Susan, welcome back to part 3, managing migraine in post-pregnancy. I want to open it up and ask kind of what changes for women post-pregnancy and what are those typical changes?
Well, there's a lot that changes, including lack of sleep, certainly. But when we look in terms of the relationship to migraine, when a woman delivers, there is a precipitous drop in the estrogen. Because remember, that estrogen has been high but fairly steady by the 3rd trimester. So that drop in estrogen can really cause a problem with migraine literally within the first 24 hours of delivery. So it's a very vulnerable time for not just women with migraine, but even women without migraine. That drop in estrogen can really be an issue.
That makes a lot of sense. And as we know from our first episode, estrogen plays an incredibly key role in migraine in women. When we're talking postpartum in general, what is that timeline we're talking about? And are there any distinct phases of?
Yeah, normally we think of postpartum as about a 6-month window. And we do think this is a vulnerable time, not just for migraine, because keep in mind that our patients with migraine, they have other conditions too. This is a very vulnerable time for postpartum depression, which is a little different than what we call the postpartum blues. It's also a time, I know speaking for my daughter, she had incredible insomnia. And then as a result, she developed anxiety. So there's just a whole host of emotions that can occur. So it's a really, really vulnerable time. But having said that, please don't let any of you as listeners make you not want to get pregnant and deliver an incredible infant. It's just a very sensitive and vulnerable time to watch out for not just migraine, but a lot of other psychological, psychiatric disorders as well.
Yeah, it's a tough time for anyone, let alone folks with migraine. And for some women, we know from last episode, migraine gets better with pregnancy. If that is true, does that continue to be true while a woman is breastfeeding? Or does it get worse again?
So that's a great point. There's a big difference when you look at what happens with migraine when women deliver. Let's say they've had a history of migraine. Maybe it got better during pregnancy. They deliver, you've got that drop in estrogen. Now, for women that choose to breastfeed, what you're doing when you breastfeed, it's almost as if your ovaries are quiet. And so you don't have the up and down hormonal fluctuations that you do if you choose not to breastfeed. So as such, the good news is for women with migraine who choose to breastfeed, most of them, not all, but most of them will notice that their migraines either don't return or they don't return with the full vengeance until either they stop breastfeeding or until their menses return. Because keep in mind that if a woman chooses to breastfeed, typically, again, because her ovaries in a sense are asleep, she's not going to be having return of menses. So I'm excited about that because we know that breastfeeding can be very good for both the mother and the infant.
That's a major pro.
That's really great to hear, and I think exciting to think about if you're planning on breastfeeding. We know though migraine can come back. There are other issues that you talked about. Do you feel that women in the postpartum phase are susceptible to many other issues or medical issues during that time?
Absolutely. And that's why I think it's so important to look for things like anxiety, depression, whether or not the woman has had it prior. I also think very important is to know what happened with prior pregnancies. If a woman in the past had just an incredible time with breastfeeding, that's exciting. But let's say looking back at previous pregnancies, she really struggled either with postpartum depression or migraine. Knowing what has happened with previous pregnancies can really help us prepare with future pregnancies.
That's really important. Yeah.
We talked about in the last episode, what are the resources for people during pregnancy? We know a lot of drugs make it into breast milk. What's a good source for a reader, or sorry, I'm not ready to do that. What's a good, let me redo that again. What's a good place for our listeners to go for information on medicines and breastfeeding?
Well, first of all, there's an incredible free online resource called LactMed, like LactMed. It's an online database that is updated regularly. And basically, when you go in, and again, it's free access, you put in the name of the medication. Let's say it was Ubrelvy or Nortec or Imitrex, and then it will pull up what we know. In some cases, the answer may be, pretty reassuring. Other cases, it may be risk versus benefit, but at least it gives you an idea of, okay, this is what I was on prior to pregnancy. Can I resume whatever this is? And if you're not sure, at least you can go to LactMed, you can read about it, and then talk to your healthcare provider about it.
That's a great resource, and we'll make sure to link that in the show notes.
And I also want to mention another resource. It's called HALES, HALES, and it's actually a pediatrician that pretty much devoted his career to looking at safety of medications during breastfeeding. And it's available as a hardback, it's available as a digital, but that's also been a very good resource over the years. And it's HALES, HALES, and you can even go to Amazon on that. But that's also been regarded very highly over the years.
Thank you for that. And that actually leads us to the question of, well, when should women think about breastfeeding? When should they think about choosing formula or combining the two? Is there something there that would lead them to make that decision?
I would encourage all women to breastfeed unless they had a really bad experience with it. There's a contraindication. Now, there may be certain medical conditions. Let's say a woman has cancer and she has to resume chemotherapy. There may be certain indications that there's just no way you want to breastfeed. But if you have the option, I would really encourage women with migraine to breastfeed, because not only is that breast milk great for the baby, but it will often help prevent the migraines from returning during that time of breastfeeding. So it's kind of a win-win if you ask me.
And I think what's really nice during breastfeeding is, there are some medications that were not considered safe during pregnancy that now in breastfeeding you can take. Are there any medications that you would kind of highlight during that time?
Absolutely. I think the big category that comes to mind are the non-steroidal anti-inflammatories. Things like naproxen, Motrin, Aleve, and also sometimes women have taken intramuscular, or what's called an injection of Toradol. All of those are completely safe. The one thing you would want to continue to avoid, though, is adult-strength aspirin. There's an association between adult-strength aspirin and something called Reye's syndrome, Reye, and it's pretty rare, but it's a complication of a viral illness. So apart from avoiding adult-strength aspirin, it's so wonderful you can then resume all the anti-inflammatories.
Right.
The other thing would be some of the anti-nausea medication. Zofran in particular has had a little controversy during pregnancy. But the good news is once you start breastfeeding, you can also resume the anti-nausea medications that you maybe were used to taking, like Zofran, Phenergan, Compazine. So that's really reassuring.
And do we know why there are some medications that are okay to take while breastfeeding, but not during pregnancy?
Yeah, I think a lot of it is because when you think about pregnancy, that baby is still forming. The organs are being formed. There's things going on with the heart. There's, for example, with some of the non-steroidals, if a woman were to take, let's say, Motrin, naproxen, her third trimester, it may cause premature closure of what we call the PDA. So a lot of this has to do with heart development, organ development. When you think about once the baby's born, you see the baby, hopefully if the baby's healthy, the heart, the lungs, the organs are all forming. So then it's more a matter of what percent of that drug gets into the mother's breast milk. And many of them are very low concentration, but even so, then you watch for the baby's behavior. Is the baby fussy? So, and with that, you can just stop the medication if there's adverse events. I think it's so much safer to try some medications during breastfeeding because, again, that baby, the organs have been formed. The baby's already been born.
I think that's really reassuring to moms after they've had a baby, especially if they're noticing that their migraine attacks are coming back.
Absolutely. And one word I'd like to get out there, because this is pretty new information, is some women may have been very happy with the 2 of the oral G-pants for acute treatment of migraine. That includes both Nortec, which is N-U-R-T-E-C, and Ubrelvy. And what's exciting is we now have published data that the amount of the Nortec that gets into the breast milk is incredibly low, really, really low. And because Ubrelvy is related to Nortec, I think it also would be low. So I certainly would be very comfortable if a woman wanted to resume Nortec or Ubrelvy after she delivered.
That's amazing to hear. Does that apply to Qulipta as well? Or do we know yet?
Well, we think it does because all 3 are G-pants, and that's really good because if a woman wanted to breastfeed but her migraines were starting to return, I would certainly be comfortable having her resume Qulipta and take that as a preventive. I would be more comfortable with that than these injectable monoclonal antibodies because, again, we just don't have enough data. And as we mentioned in the previous segment, Qulipta has a half-life of 11 hours versus the monoclonal antibodies where it's 27 to 31 days. Let's say a woman started Qulipta and she thought, oh, my baby's a little more fussy, or my baby's not breastfeeding as well, or my milk production is less. Then you can stop it and you're going to be back to baseline within about 2 days. So again, I think using medications that have a relatively short half-life that can be stopped if there appears to be anything negative with the infant, that's much better than using something that's going to hang out in the system for much longer.
Yeah, that's such really amazing new changes in what we know about these medications. What about the triptans? We know that, we can essentially use those during pregnancy. How about during breastfeeding?
That's a great point because so many women have been on triptans before pregnancy and some even take triptans during pregnancy. Now, I think we have the most data with sumatriptan, which is Imitrex. And that's both oral, nasal, and injectable. I think it's becoming pretty common to let women resume the triptan. Again, you look for any jitteriness, any adverse effects on the infant, but I certainly have not seen a negative. But I think, again, it comes down to benefit versus risk. But I'm certainly not seeing anything published that appears to be negative. But having said that, let's say a woman was thinking, okay, I want to resume my triptan, but I'm not sure. Well, you can do something called pump and discard. What does that mean? Let's say you were really having a bad headache day. Well, maybe that day you switch to formula for the baby and you take your triptan. Or maybe the next time let's say you breastfeed, then you take your triptan after you breastfeed because then it will be a number of hours before you breastfeed. So there's a lot of what I would say trial and error. There's a lot of things you can do with the timing of when you take your medication, when you breastfeed. But just a quick note, this might be a great time for injectable sumatriptan with a relatively short half-life because you could take that injection and maybe 3 hours later breastfeed. But I personally think the data looks to be more and more reassuring that the triptans are safe during breastfeeding.
Yeah, that's really great to hear. And I think it helps reassure moms after they've had a baby that there are options to take acutely when you do have a migraine. What about the kind of maybe some of those oral preventive medications, those older oral medications? Are those safe while breastfeeding?
Yeah, here's what I can tell you. I just looked up topiramate on LactMed, believe it or not, before I came on, knowing that many women may have been on Topamax or topiramate. Most infants tolerate it well, but there have been some cases of both sedation and diarrhea. Now, that's not life and death, but when you think about topiramate, which is Topamax, it can make a woman sleepy, so it does get into the breast milk. So if you had a preventive, why not go to LactMed and look it up? The other area that I think there is a concern is some of the blood pressure medications. I think the beta blockers would be okay, but I'm not too sure about Candesartan, which is Atacand. So I think with some of the blood pressure medications that are not the beta blockers, they are either what are called ARBs or ACE inhibitors. I believe there is some concern. So even that, even me, I would have to look up on LactMed to say, what would he know? Now, I will tell you, I think most of the antidepressants would be quite safe to resume, and that's really important because an antidepressant could also help treat or prevent postpartum depression. So I would be perfectly fine if a woman needed to resume, let's say, her Prozac, her Zoloft, her Lexapro. And I think it would be probably fine with things like Effexor and Cymbalta. But again, things can change. So I would also encourage you, if you're listening to this, but you're not sure, go to LactMed, because that's going to be more up to date and kept up to date as new research, comes into play.
What a wonderful resource to have.
It really is.
Wish there was something more public like that for during pregnancy, as we talked about in the last episode.
I do also. And I think we should mention Botox. Botox, even though it does have a long half-life and you get it every 12 hours, I would be okay a woman resuming that because, again, these are intramuscular superficial injections. There's evidence that very, very little would get into the blood system. And from there, very, very, very little, if any, would get into the breast milk. So there again, that's something I would be comfortable having a woman resume would be Botox.
We probably should have covered this in the last episode, but I don't believe there's ever even been a case of a woman getting, or anybody getting botulism actually from Botox. Is that correct?
Correct. I mean, that would be from getting a much, much higher dose. And the doses that we give for migraine would not be expected to have a risk of botulism.
Moving on to more natural remedies or the supplements that we always talk about, kind of working with preventive or abortive medications, what are the natural options for women breastfeeding to take for migraine prevention?
That's a good point. Certainly a woman could continue both B2, which is riboflavin, and magnesium, and those are safe during pregnancy. I think with breastfeeding, if a woman really wanted to resume, let's say, CoQ10, maybe she really wanted to resume taking some melatonin at night, I would be okay with that because, again, you're going to be watching that baby. Mainly what you're doing is looking if there any change in sleep behavior, fussiness, food intake. That even happens, I believe, with different foods that women might eat. They eat a food that doesn't agree with the baby. Well, that's how you learn. But again, I can't stress enough, it's so much safer when looking at medications, when that baby's already born, the heart's formed, the lungs, the liver, the kidneys, the arms and legs are there. So it's just so much different and so much safer with breastfeeding. But again, aspirin is not a good idea, adult strength aspirin. And I would not recommend the newer CGRP monoclonal antibodies at this time until we have more information.
And we know that you mentioned magnesium during pregnancy, and it's okay to keep doing that. I'm going to assume it's okay also during breastfeeding?
Yes, and again, I don't honestly know how much gets into the breast milk, but because diarrhea and GI would be the most common side effects in a woman, I would also watch for that in the infant. Another thing I want to point out before we conclude is that there's also a big difference between how are you going to manage breastfeeding and medication with a baby who's premature versus relatively newborn versus when you get out 3 months, 6 months, 9 months. Because I've known women that breastfeed when the kid's 2 years old. So, the more mature the infant, that infant's liver and kidney is going to be more mature, therefore better able to metabolize and eliminate whatever drug milk gets into the mother's breast milk. So maybe a mother might be a little bit nervous the first few months, and maybe she wants to do the pump and discard. But I think as the baby matures and it gets to be 3 and 6 months old, you don't have to be quite as careful.
Are there any examples of things that are safer at that 3 or 6 month stage versus that pre 3 or 6 month stage?
Yeah, I think the triptans, I wouldn't recommend you have to deal with the pump and discard. That would be the main thing, because I think, again, already your anti-nausea medications, your G-pants, I think would be perfectly safe. But I think it's more reassuring to the woman, and perhaps this might also apply to medications that a woman's taking that are outside of migraine, as perhaps a woman's on other medication for other medical conditions. The one thing I would recommend, though, is really try not to take narcotics, opioids, barbiturates. Not only are those not really have evidence for treating migraine, but those could make the baby sleepy. I mean, if it makes the woman sleepy. So really, if you're listening and you take any kind of a narcotic or opioid, things like codeine, Vicodin, please reach out to us at Haven if we can. If you're here in the state of California, and if you're not, reach out to your provider and try to be on more migraine-specific medication and try to completely eliminate narcotics, opioids, and barbiturates.
And just as kind of a reminder, these drugs are not considered useful for headache and migraine disorders. And for those visiting Haven, we have a completely opioid and barbiturate free policy at Haven, which is just really important as a message who might be working through doctors who are on some of the evidence from 30 years ago, which kind of happens. And we see it a lot actually here at Haven, and have to really work to wean folks off of those, make sure that that is something you're saying no to as a part of your headache and migraine disorders.
Yeah, I agree. And that's the reason I bring it up, Isaac and Netta, is that some well-meaning physicians, whether it be OBGYN or pediatrician, they're not used to some of these newer medications. So sometimes they fall back on what they know. And unfortunately, that's some of these older preparations that maybe years ago, there was a place for treating bad migraine because we didn't have all these other options. But really, personally, I think we at Haven agree there's no place for narcotics or butabitol, which is a barbiturate, in the treatment of migraine.
Yeah, I totally agree. And so let's say we do have a case where a mom is breastfeeding and she does take, a migraine specific medication. How long should she wait before she breastfeeds? Is there kind of a certain amount of time or hours she should wait?
Part of that's going to depend on what the pattern is she's established with breastfeeding, because I know when our daughter breastfed, she felt like every 2 to 3 hours her son wanted to breastfeed. Yeah. But ideally, if a woman took the medication, I think if she could wait 4 to 6 hours, if it was an oral treatment, that may mean having to pump and discard, that may mean having the baby get used to formula. So I guess in a perfect world, it would be nice if a woman with migraine who chooses to breastfeed could at least introduce some formula feeding, so that if she had a really tough migraine, that she or her husband could do the formula for that day.
Could another strategy be to sort of reserve some extra breast milk and freeze for those moments when you have to do that pump and dump?
That is an excellent suggestion. So in other words, pumping milk and having it set aside, and that milk doesn't have any of the medication. That's an excellent idea.
I think that's really helpful for new moms. And Susan, is there anything else you'd like to add about breastfeeding and migraine that we haven't covered?
I think the main thing is to really encourage women to breastfeed if you want to. That if anything, again, it could be a win-win. Not only is it good for the infant, but there's a very good chance that it will delay the return of your migraine, which is really exciting.
Well, thank you so much, Susan. And you'll be joining us back for the next episode on perimenopause and menopause, which we know is also a kind of troubling time for women as well. Thank you so much, and we'll see you soon.
Thanks, Susan.
Thank you. It was a pleasure.